A very good morning to Rohit sir and a very good evening to everyone else. I have a case of multifaceted dermatomyositis which I am going to discuss today. So my patient is a 44-year-old serving soldier in the Indian Army, a non-smoker, a native of Himachal Pradesh, but presently residing in Delhi for the past 4 years. So he initially presented in May 2021 to the Department of Pulmonology with the chief complaints of, sorry, with the chief complaints of dyspnea on exertion, dry cough. He was found to have tachypnea as well as hypoxemia of 93% on room air. May 2020 to 2022 being the COVID pandemic era, he was very naturally being considered as a COVID suspect and was investigated accordingly. So his inflammatory markers were essentially normal, but a qualitative CRP was positive. He was ruled out to have any active infection, but was found to have reticular basal opacities on a chest X-ray, which was confirmed to be ILD on an HRCT chest. He had mild restriction and a severe diffusion defect on PFT and DLCO respectively. RT-PCR for COVID-19 was surprisingly negative. However, in view of strong clinical suspicion, an antibody was tested and he was found to be positive for IgM and IgG. So with a strong suspicion of COVID-19, he was managed as a moderate COVID-19 illness with post-COVID sequelae with steroids, oxygen, anticoagulants, bronchodilators, antifibrotics, and had a good response. He was also managed with oral steroids to the tune of 1 mg per kg, which were gradually tapered down to 5 mg per day. And the patient was doing well from May 2021 to October 2022 with a good response in spirometry as well. However, in the October of 2022, he now presented, or in fact was referred by the pulmonologist to the skin specialist with a generalized skin rash, inflammatory polyarthritis, and significant unintentional weight loss. So they naturally investigated him. They did a skin biopsy, which was consistent with the diagnosis of a rash of DLE. They did a limited immune workup, which revealed a negative RF, a positive CRP, and ANA positivity with a UVIN RN positivity on LIA. So he was referred to our center under rheumatology with a provisional diagnosis of overlap CTD. When the patient presented to us, we revisited the history. We already knew about his ILD, inflammatory arthritis, and skin rash. However, he did give history of a similar skin rash at the onset of ILD in May 2021, which was obviously ignored because of his predominant chest symptoms. During the hospital stay, since it was winters, he also developed Raynaud's. So on examination, his vitals were stable. He had typical cutaneous lesions, which I'll go on to the next slide. He had a tenderness in his wrist, knees, small joints of hands. He had no muscle weakness. However, he had basal crackles, suggestive of pre-existing ILD. His cardiovascular and other systemic examination was normal, and his PFT was much better than his baseline parameters. We did an NFC, which revealed the classical findings seen in dermatomyositis. That is, he had giant capillaries, megacapillaries, arborization of capillaries, reduced capillary density, but no microhemorrhages. So these were his skin lesions. He had a heliotrope rash. He had periorbital swelling. He had poikiloderma on his forehead. He had inverse Gottron's. He had Gottron's papules. He had Hiker's feet. He had Gottron sign on his elbows and shoulders as well. And he had mechanic's hand. So his blood investigations revealed lymphopenia. Others were essentially normal. His biochemistry revealed normal muscle enzymes, but with mildly elevated LTH with a cutoff of 290. His inflammatory markers was normal. However, ferritin was 648. His imaging was within normal limits, and a repeat HRCT chest revealed no significant change. I'm apologetic for the spelling mistake. So within immune workup revealed an ANA positivity with a nucleolar homogeneous pattern. His LIA was negative. However, in strong suspicion of dermatomyositis, we did a myositis blot, which shown positively for MDF5 with single positivity for Me2, SRP, SAE, as well as TIF-gamma. His other immunological parameters, C3, C4 were normal since he came with a diagnosis of overlap CTD, and he had hypergammaglobulinemia. So with the diagnosis of amyopathic MDF5 dermatomyositis, we managed him with tacrolimus, tadalafil and amlodipine for his vasculopathy, and prednisolone. And he had good response clinically as well as resolution of lymphopenia by February 2023. However, he came to us the next month in March 2023 with progression of skin disease as well as new onset ulcers over his fingertips. So we increased the tacrolimus, we increased the steroids, and we gave him 2 doses of rituximab. So by 3 months more later, in June 2023, the patient came to us. He had persistent skin disease and he developed a new onset right knee synovitis. The CDACs calculated at this time revealed a score of 17 for activity and 1 for damage. We did image him to see for internal activity and we found a radiological increase in the GGOs. However, his PFTs were better. He had persistent lymphopenia, increased ferritin levels, subnormal TAC levels also. After establishing synovitis, synovial proliferation, and positive Doppler on ultrasound, we gave him intraarticular. And after a multidisciplinary discussion with the radiology as well as pulmonology team, we added him on JAK inhibitors as well as bosentan for his skin disease. So 6 months again later, he continued to have persistent cutaneous disease and Raynaud's, all thanks to winters. He persisted to have inflammation, raised LDH, raised ferritin, wherein we further increased his tacrolimus. So this was December. However, in April 2024, the poor guy presented to us with increased lesions in hands, persistent heliotrope, and new onset ulcers over his penile area this time. And he had new onset constitutional symptoms as well. And understandably, his inflammatory markers were still elevated. He had persistent lymphopenia. He had persistent raised ferritin levels. HRCT chest was essentially the same. However, he had dip in his spirometry as well as TLCO. He had no features to suggest PAH at this time. So in view of progression of ILD as well as skin, we went ahead and gave him IVIG and added mycophenolate mofetil. After optimizing the dose of MMF, we stopped his TOFA since he had been on TOFA for around a year with no response in clinical symptoms. Also, for his bad, painful ulcers, he also underwent platelet-rich fibrin dressing weekly under dermatology with very good response.
1 minute left.
So after June, in June, he was admitted for the 3rd dose of IVIG. He was doing relatively well with good response in skin rash. However, this time he had active myositis clinically and a left wrist arthritis. And on investigations, his MRI thighs again showed active myositis for the first time. So we gave him cyclophosphamide and added methotrexate. We continued on IVIG in view of good response in skin. So by August, when he was admitted for the 5th dose of IVIG, we noticed him to be breathless at rest. He did not give any complaints though. Clinical examination did reveal features of PAH with increase in his bibasilar crackles also. So progression of ILD and new onset PAH was confirmed on an echo as well as HRCT chest. So this time we did go back to B-cell depletion. With poor response to rituximab, we tried and gave him obinutuzumab, 2 doses of 1 gram each. We added apremilast for his cutaneous disease and ulcers. We restarted tacrolimus, thinking of him doing well on tacrolimus initially with his myositis and ILD being checked. And we did increase in steroids to the dose of myositis regime. So thankfully, he's doing very well. He has resolution of his ulcers, rash, and his facial appearance as well. However, in view of persistent arthralgias, X-rays were done and he was found to have calcinosis universalis. So we did add alendronate to his existing regime. Thank you.